October the 9th, 2020. This is the RheumNow podcast. Hi, I'm Dr. Jack Cush, executive editor of RheumNow.com. This week, the consequences of COVID. Bad disease and bad outcomes, bad news. And what do you call that punched out, gouty x-ray change? I've got a name. Actually, I've got several names. We're going to start out with COVID news. An interesting study came out this week that compares COVID to influenza. And it actually uses large population-based data, 6 months of COVID data versus 1 year of influenza data from Korea, Spain, and the United States. So they compared 34,000 COVID patients to 84,000 influenza patients. They basically showed that COVID-19 patients were more likely to be younger, male, and have fewer comorbidities, and basically take less medications than do patients with the flu. Again, we know the death rates are high. We know that the consequences of COVID compared to flu it's either 7 times more prevalent or 14 times more prevalent, depending on who you look at. And certainly the death rates are more disastrous. But this shows you the sort of the clinical profile. And it fits with what we said last week in that, yes, early on in COVID, there were a lot of elderly people, and those were the ones who were dying. Now that we're 6 months into it, the ones who are being hospitalized are in the 20 to 29 age group. That kind of fits with this data. Another study came out this week on the heels of the president getting dexamethasone and being miraculously cured in the infectious wing of the White House. Steroids can help mortality rates in COVID-19. 7 is meta-analysis, 7 randomized trials, 1,700 patients who either received dexamethasone, hydrocortisone, or methylprednisolone, about 700 patients who were compared to about 1,000 patients who received usual care or placebo. They basically showed about 1 in 3 patients treated with dexamethasone died, 222 out of 678, versus 4 out of 10 who died when they got usual care, suggesting about a 10% reduction in overall mortality, and that was significant. In fact, the odds ratio showed about a 1/3 reduction in overall mortality. That was very significant. An interesting UK survey study came out, and I have this idea, I have some data I'm accumulating on the consequences of COVID, the aftermath, if you will, that of the bad things that have happened while we were shutting down, while we were changing our lifestyles, while patients were being cared for or not being cared for. In this large cohort from the UK, almost 700 patients, they actually had survey data soon after COVID. And they took their survey data about 6 weeks after COVID started and showed that 53% had self-reported worsening of disease. 1/3 had access problems with their hospital or their clinic. Yet 88% were able to get their meds and their refills, and all that seemed well. But still, of those, about half of them still required help, meaning that they were older people or they seemed to need help with a change in technology in getting their meds to them. So this is one of several examples. You know about patients who are probably not getting their cancer care, their bone density treatments or screenings. There are a number of things that are happening during COVID that we're going to find out. It's not quite as simple as the lost income and the disruption of our lives. There's a lot of things that are going to happen as a result of COVID that we're going to find out in the next few months. That's what happens with lockdown. I found this interesting study, reported it yesterday as a tweet. It's a study of almost 200 patients with axial spondyloarthritis who undergo switching of TNF inhibitors. We tend to love to switch TNF inhibitors. If one doesn't work, let's try a second. If that doesn't work, we can try a third. I'm not a big advocate for that. I would say that after you've failed one TNF inhibitor, you should often go to another MOA in RA. And the data is pretty clear that in RA, when you start going from first to second to third, you lose efficacy, meaning ACR20, which should be 60-40-20 with the first one, becomes 50-30-15 with the second, or maybe even worse. And this is a study showing the same thing in patients with ankylosing spondylitis, actually axial spondyloarthritis. So using the most stringent criteria for outcomes, the ASDAS-ID, I can't keep up with the ASDAS people, the ASAS people who are coming up with new measures all the time. But nonetheless, the most stringent measure of outcomes shows that you're going to do okay if you stay within the TNF class. You switch from first to second if you're switching for the purposes of a secondary non-response, meaning they once responded, you lost response. You actually don't lose much in the way of response, or if you're switching for adverse events. But when you compare those two reasons for switching to primary non-response, they're way better, 7 to 9 times better than those who have a primary TNF failure, meaning as soon as you got your first TNF inhibitor, you never got better. That's your clue to switch. This works in and applies to, in this case, spondyloarthritis. It also applies to RA. I'm sure it applies the same way with psoriatic arthritis. In fact, there is data to suggest that. A new biologic hit the markets, a new study with an anti-GM-CSF monoclonal antibody studied in 22 patients. 22. Let's try 222 patients with rheumatoid arthritis. The drug is called otilimab, Otilimab. This is an early phase 2 trial where they trying 5 different doses versus placebo. The drug is given weekly for 5 weeks and then every other week thereafter. It was a 1-year study. The primary endpoint was at 6 months. And guess what? At 6 months, it didn't look good. The 5 doses were 22, 45, 90, 135, or 180, or placebo. Again, the DAS-CRP remission rates, DAS-CRP less than 2.6, was like 5%, 16%, 19%, 14%, got no better than 14 to 19%. Again, you'd sort of like to see an RA somewhere in the range of 30% or higher. So this did not meet its primary endpoint. They talked about it with some degree of encouragement, but I look at this data and say, this is a crash and burn. The placebo response rate was 3%. So yes, it was better than placebo, not with the lowest dose. The other doses were better, but I'm not certain what's going to happen with this anti-GM-CSF monoclonal antibody. There's an interesting study that came out from a Greek registry, the Hellenic registry. This includes 385 patients, and it looked at patients who were in remission or low disease activity state and compared them to those who had moderate disease activity and higher. So patients with worse disease, what happens to them? Well, turns out they actually had 50 to 80% more serious adverse events. That's something we've seen over and over again. Patients who have the best response, you know what? They tend to have the least amount of adverse events, especially even serious adverse events. Patients with the worst response, that's where all the serious adverse events, SIEs, cancer, death, malignancy, whatever, those occur in people who don't respond well. There's something about efficacy and safety that, in fact, does go hand in hand. Bad disease, expect bad outcomes. That, unfortunately, applies to many situations. So lupus and lupus cerebritis can present as psychosis. We don't see much psychosis, but it can sort of appear. There was an interesting study that came from one of the psych journals about 476 mental health patients who were admitted to the hospital for psychosis. Could they possibly have lupus? Could they have autoimmune disease? Could they have neuropsychiatric lupus? Well, of the cohort that was tested, it wasn't all 4,700. I think it was, 300-400. 19% had actually 19% were tested, and 135 had a positive ANA at a titer of 1 to 160 or higher, meaning that 15% of those tested were ANA positive. I can tell you, as someone who screened a lot of autoantibody positive results looking for early disease, you find a lot of positive autoantibodies without necessarily having the disease in the psych population. So 15% are ANA positive. To me, I kind of expected that. But of those 135, only 4 met criteria for lupus. And only 2 of those 4 actually had criteria for neuropsychiatric lupus. So, de novo incident psychosis, could that be the presenting feature of neuropsychiatric lupus? Not a chance. Not a chance. When it is, there'll be many manifestations of lupus. They'll meet criteria real easy. And yes, neuropsychiatric lupus could be the presentation. But again, psychosis masquerading as lupus is really not likely. So I asked you earlier, that scooped out lesion that you see in gout? It's different than RA lesions, which are a little bit of a rat bite. on the corner at the articular synovial junction. These are a little bit lower, and they're lucent lesions that have a scooped out appearance. It's got a name. Actually, it was first described by the famous radiologist from University of Michigan, Dr. William Martell. So it's called the Martell sign. It also is called the G sign. Think about it, G, or rat bite erosion. I just said the rat bite erosion is what you saw in RA. That's the wrong name. But a G sign I like, the scooped out erosion I like, but now I'm going to call it the Martell sign after Dr. William Martell. Again, it is a lesion that is a scooped out lesion with a sclerotic margin and an overhanging edge. Those are the classic features of the gout radiographic change. So what about risk of future damage in spondyloarthritis? What better population to look at than an early spondyloarthritis population as found in the DESIR cohort, 406 patients with axial spondyloarthritis, and they were followed over five years. They showed that smoking was a risk factor for developing 5 years later MR evidence of sacral iliitis and MR evidence of lumbar disease as well. Turns out that actually this was even higher in blue collar job individuals and those who had low education levels, which is a little bit like what you see with psoriatic arthritis and psoriasis, where trauma is a major inciting factor or risk factor for future arthritis. They're suggesting that blue collar jobs or mechanical stress may be a risk factor for developing sacral iliitis and spondylitis in these early spondyloarthritis patients. An interesting concept. Our last report comes from that CANTOS study. We've talked about it a lot in the past. Remember, the CANTOS study was the canakinumab study looking at its effect as an IL-1 inhibitor in patients who are high-risk cardiac patients who go into the study with an elevated CRP, and it showed that, yes, an IL-1 inhibitor is capable of reducing cardiovascular events and cardiovascular death. Other spin-offs from that study, it was a 10,000 patient trial. Again, none of them had to have arthritis getting in. They found that patients who were on canakinumab compared to those who weren't were less likely to have new incident gout. They found they were less likely to have death. They were less likely to have lung cancer. Again, these are all surprising findings. This particular report looks at the risk of future arthroplasty. So a small subset of these people going into the study did have osteoarthritis, but most did not. And they were looking at the risk of future total hip replacement or total knee replacement. And again, it was comparing placebo-treated patients to those who received one of the 5 different doses of canakinumab, 50, 150, or 300 every 8 weeks. Altogether, those who received canakinumab had a 42% lower risk of developing the need for joint arthroplasty. This does suggest that IL-1 inhibition could be effective therapy, but there have been studies looking at IL-1 inhibition in treating osteoarthritis of the hand. Again, it might be a cohort, an entry cohort criteria that may give you different results, maybe very early, for people who are at high risk but don't yet have, grade 3 or higher osteoarthritis of the knee. This is an interesting finding. Anyway, that's it for this week on RheumNow and our podcast. Go to the website to find citations for these reports and more. Again, I want to encourage you to click on Back Talk and present your case or ask me your question. We will feature those in future editions of the podcast. And lastly, I want you to be on the lookout for all that we're going to be doing for ACR 2020, the virtual meeting. RheumNow's got a wild and crazy plan, and what we want you to do is give us 2 hours and we'll deliver the meeting to you. It's our promise, and we're working hard to make sure that happens. Thanks for tuning in. See you next week.